right, guys, sorry about that. I have no idea what happened there. But it wasn't.
Hi, Doc. Sorry to disturb you. I think there are a few waiting to come in from your actual group. So, yeah.
Okay. All right, I like that. All right. Let me just close my other presentation. They're picking up all of them. Okay. All right, guys. So just give you the opportunity to the case. Okay, here we go. All right, so let's back up. This is a case. 65-year-old female, 10-year history of hypertension, 36-hour history, slurred speech, blurred vision, inability to ambulate, worsening confusion. And the background is that her daughter found her basically, noted her face was twisted to one side, she was drowsy, not following instructions, why she attempted to get progress for hospital. So she basically had visited her. Last time she had seen her was 30, or spoken to her was 36 hours prior to that. And that's all the history that we got when she showed up to a hospital. So for virtual rounds, this is essentially what we do on the wards. You will elicit a history. You probably will have a history from your A&E officer when you're on internal medicine, or if you're the first person to see the patient, you have to elicit the whole history yourself. So invariably, you will be taking a history, even if you are just soaping the patient. There will be questions you want to ask to verify, to understand and clarify the history. We'll go through the physical examination. And of course, we examine all patients, basically all systems, general exam, all systems examinations. But depending on the presenting complaint of the patient, you're going to find you're going to hone in more on one particular system than others. And that's only natural, right, to keep focused. And then after a history and a physical examination, you should be able to come up with a list of differential diagnoses. If you're not able to do that, then there is something fundamentally wrong with the history. And most times it's the history. There is something missing from the picture. You may not get the specific diagnosis right off the bat, but definitely a differential diagnosis is well within reach after doing a competent history physical examination. And then, of course, patients always come with some results, or by the time you've seen them, they do have some investigations available. We review them, and then we determine what else we would actually have to ask the patient to get for the patient. And how we approach a patient in terms of management. Under management, we talk about investigations, the pharmacological management, the non-pharmacological management, and supportive care where relevant, reviewing prognosis and determining what's the further future management for the patient. And this is all a part of determining the long-term care of the patient, and specifically for patients admitted for discharge planning. Now, you see the emphasis is on evidence-based management. So you guys definitely read Harrison's, read all your textbooks for medicine. However, when it comes to management, especially chronic non-communicable diseases like hypertension, diabetes, asthma, stroke, all of these, the management principles are guideline-based. There is usually a society, so American Heart Association, the American College of Rheumatology, the American Diabetes Association. We do have local guidelines as well. However, the point is that when you read your textbook, by the time your textbook goes to print, there will be a guideline which is not in that textbook. So you have to rely on on guidelines, societal guidelines to determine how you manage patients. Every year there's a new diabetes guideline. Every year there's a new hypertension guideline. And so you have to be very much aware of this, because all management is evidence-based. And every year there's new evidence. There's a clinical trial, there's a new drug, there is a new investigational approach, a new immunological test, and so on, all across medicine. So I have to stress this for management. Try to focus on societal guidelines if you want to be current. And then, of course, at the end of each case, you do it intuitively. We'll do it specifically. because we're teaching, but you do it intuitively. What have I learned from this case? What's the takeaway point? Every day, every week, there is something that I picked up on the ward that's new. It may just be a small nugget, but there are always pearls. Because in medicine, what you find is a lot of pattern recognition. If you've seen a case before, you've seen stroke. You probably will have seen many strokes, or I've seen many, hundreds of people present with stroke, but we may pick up somebody who has come with a new kind of neurological presentation, or something new in the history, which is kind of interesting, and you kind of keep that in the background, going forward. So we'll focus on pearls, and pearls help us to pick up on things in the future once you have that in your head. And so let's go back to the case and talk about the case. So what more history do you want for this patient? More history. And so I have to focus on my guys, my 5. Omar, what else do you want in the history?
So I would like to know if a situation like this have happened before, and the patient baseline functions.
I'm not hearing you so well.
You hear me better now?
Little bit. Okay, go ahead.
It's better?
Yes.
Okay. So I was saying I'd like to know if an incident like this have happened before.
No. Okay.
And because I'm going on the definition of this patient having a stroke, I'd like to know their baseline function. So
excellent. Let's take a pin right there. So you mentioned 2 things. You want to know if this has happened before. Always, whenever somebody presents something, you want to know if this has happened before. But specifically, I think you want to know if the patient has had any neurological deficits presenting or manifesting in the past. And the answer to that is no. But you've hit a very important point. Whenever patients present with any altered mental state, anything that has changed in their sensorium, any neurological deficit, we must establish their baseline status. It's very important because we need to know how different is this patient. We have patients who come with multiple stroke. So this patient, the patients with dementia who come in with what the relatives think to be an acute confusional state, but they weren't normal at their baseline because they had the dementia. It's important to know how different the patient is also for establishing realistic goals. So if the patient had baseline dementia and they're now confused because they're septic, they have a UTI, that's how elderly people present with infections. A lot of the time, they're not themselves. They're confused. They may hallucinate. They're disoriented. Not eating. So, and if the patient already had dementia and was existing in that state, then you want to know how much different the patient is, so you can establish what the goal is. You're not looking to discharge somebody who has a normal mental status because the patient was not normal in the first places. And very key point, you have to determine what the baseline status of the patient is. So I'll tell you that this patient was ambulant, conversant, self-caring, she had normal executive function, she conducts all her personal activities, business activities on her own without any assistance. So that's her baseline. She has no prior history of any symptoms similar to this, no history of stroke in the past. And since you're talking about, the background of the patient, one of the first things you must establish is the chronic disease. So she has hypertension. Interested in knowing how long she's had a 10-year history of hypertension. When you see somebody with hypertension, diabetes, you want to know what about their hypertension, diabetes. She doesn't have diabetes, but I'm just going to throw that in there for, as we say, expansion of knowledge and just to establish certain principles. Anybody with any chronic medical illness that has any cardiovascular complications, what's the follow-up history to, okay, you have a 10-year history of hypertension. What other history do you want to elicit right away and tag on to that background history? So, Omar, you chose to go in the background before we talk about the history of presenting complaint. That's the right approach. So what else do you want to know about the background of this hypertensive patient?
Yes. Okay. So with chronic illness, I was going into that. So, what medication is she taking for them? Is she compliant on medications? Are they working? Right. Overall control on our chronic illnesses.
Okay. Right. Any vascular complications you want to know? So she may not have had a stroke before, but does she have cardiovascular disease? Has she had an MI in the past? Does she have heart disease? So because, that will tell you that this patient has a high risk of having another vascular event, which may be, in this case, in the brain. So anybody with hypertension, diabetes, do they have any previous cardiovascular complications? That includes myocardial infarction, stroke, you know, peripheral arterial disease, whatnot. In the case of diabetes specifically, you want to ask microvascular and macrovascular complications. So this lady has a 10-year history of hypertension. She has no vascular complications in the past. Right. Is there anything else when you think about hypertension and this presenting complaint that you want to specifically ask about in terms of background history? We're going to test for it, but is there anything else you're thinking about? The patients may not necessarily tell you. It's another principle. And until you're practicing taking the history, you will realize that patients don't always know all of their diagnosis, and they don't always tell you everything that they're being treated for, because some things they don't think are relevant or it's under control, so it's no longer a problem. Anything else other than the vascular complications you'd want to know if this patient has?
I'm thinking along the line of syncope, if they ever blocked out before.
Okay. So no, I wouldn't think that's low yield right now in terms of any chronic illnesses. Amar, you've done so well so far, so I'm going to give you a break. Anyone else wants to jump in? Amelia? Anything else? Yeah.
You're asking about anything in the background history?
Yes,
like
ma'am.
Smoking.
All right. So that's a good point, yeah. But give me something else in terms of disease. So
Cholesterol.
yes, so there's a patient have hypercholesterolemia. The daughter doesn't know, the mom can't give a history, but that's pertinent to ask about in the background history, right? So then Omar said we ask about the medications that the patient is on and compliance. So definitely we need to know the medications the patient is on. And Amelia, how do you elicit that history? So I'm going to be the one who's giving you the history, right? How do you elicit that history?
Okay. So are you on any medication?
Right. So the doctor's one who's going to answer, and she says yes, she takes losartan, 50 milligrams once a day, and that's the only thing she takes for her hypertension. She believes she's compliant because she's always filling her prescription, but she also has some other medications. So here's
the name.
Go ahead.
You know the names of those other medications?
Okay, so she's taking Lipitor, atorvastatin, 20 milligrams once a day.
Okay.
What are your thoughts on hearing she's taking Lipitor, atorvastatin, 20 milligrams once a day?
That she has a underlying cholesterol disease.
Right. Yeah, she does. And the interesting thing is that patients will not necessarily tell you about that because their last cholesterol level was normal. So in their mind, they don't have a problem with cholesterol anymore. So it's not on their problem list, but it needs to be on our problem list. The other thing I want to tell you about in terms of practical approach to taking the history from patients, right? So this is a case, but we're talking about the approach to the history and getting information from patients in general on medicine. You must ask the patient, show me your medication. Let them take out the bag, the box, whatever it is, and preferably you want to look at the medications in their original containers. Show me all the tablets you're taking. That's when you'll realize, that is how we picked up that the patient was being treated for hypercholesterolemia, because she has other medications she's taking, and we looked at them and we saw she has atorvastatin. So obviously she's being treated for hypercholesterolemia. It's very important to actually look at the medications that patients are taking because, number one, many times patients don't know what medications they're taking. They'll tell you they take one white one, one yellow one that's shaped like a square, and one that's shaped like an egg. And that's not going to help you any at all. It's important to also ask the patient about how long they're taking these medications, because if there's any recent medication change, which may be associated with whatever it is that they may be presenting with. So a patient is now presenting with hypoglycemia, but this patient had their metformin increase last week. So it's not just, okay, what medications you're taking? Okay, thank you. Try to actually see the medications, the actual containers and stuff. If they don't have it, so send the daughter home, send the relative home to bring them to the ward tomorrow so we can look at them. If they don't have the medication, so it's finished, or they have them in pill boxes, like, Monday, Tuesday, Wednesday, Thursday, Friday, ask them for an old prescription. Let me see your most recent prescription. And it's important to look at the date of the prescription, because oftentimes medications are changed. We see it all the time. We change the medication, but they fill the old prescription. And you wonder why the sugar is so high. Then you're going to increase the metformin or increase the antihypertensive when really they're taking the old one. And so that's why they haven't. So on medicine, there's a lot of practicality in listing a history. It's not just sit down, take the history. We have to actively engage in really trying to decipher what's happening with the patient. So that's some practical tips, and you do it for any patient presenting with any complaint. All right, so that's a general principle I just want to highlight. So she's taking losartan 50 milligrams once a day. She's taking Lipitor 20 milligrams once a day. She's apparently been on them for as far as the daughter can remember. She knows that she feels these two things on the prescription. Okay, all right, so let's speed it along now. Anything else in the history? Chantal, anything else in the history? Chantal? We don't reach anywhere yet, we haven't done history of presenting complaint yet. Right? We're getting the background history is always very important. It informs, you've gotten a lot of information now about this patient already just from the background history. Right? So anything else in the history? All right, anybody jump in? Anika?
Doc, you could ask about maybe she's taking some oral contraceptive for postmenopausal symptoms that could create.
Any hormones? No, she's not on anything else. That's all she's on in terms of medications, and no drug allergies. Yeah.
Okay.
That's it for our medication history.
Okay.
Yeah. All right. Anything you want to know about the history? Anything you want to know about the history?
Doc?
Yes. Brittany.
Hi. Yes. Hi, I'm an intruder. But I was wondering if maybe we could ask about any history of trauma or a fall.
Okay, so there was no history of, not that we know of. That's a very good question, because she last spoke to her 36 hours ago when she came to see her. This is how she found her, but not that we know of. The patient can give us some amount of history, but not her information was not consistent because she was confused. But that's a good question. There was no history of any fall that we know of. And when we go to physical examination, we didn't see any evidence just to support that, but that's a good thought. That's there. Anything else? Anything else, Misha?
Any history of seizures?
So she has no history of seizures in the past. Her past medical history, other than hypertension and apparent hypercholesterolemia, is unremarkable. She has no past surgical history, and this is a medication she's on, and she has no allergies to anything else. Nothing else in terms of her history. Did she have seizures this time, you mean, with the presenting complaint?
Yes, that too.
Okay, that's what you mean. Perfect. That's an excellent question. All right. So, not that we know of, certainly not witnessed, but anybody who presents with a neurological deficit, a history of seizures is very, very, very important. It's important for localization, as you soon will find out. It's also important for determining the further management of the patient, right? So, yes, any history of seizures. And no history of seizures that we could really be certain of. The patient couldn't give a history. The daughter basically found her 36 hours later, so we're not sure. Did we see any surrogates of history? Did she have any blood coming from the mouth? Did her daughter find her with any evidence of fecal or urinary incontinence? No, nothing like that was noted when she was found by her daughter. That's an excellent question.
I also want to know, I saw that she can't ambulate, but is it localized to one side? Like, is one side weaker than the other?
So her daughter does think that she was dragging one side of the body. She kind of thought it was dragging her right side a bit, and that's why she picked up. She was having difficulty walking. She kept falling down.
Okay.
Anything else in the history? Anything else in the history?
Hey, Doc.
Yes.
So is it okay to ask, like, if between finding her, bringing her to the hospital, did she improve in her symptoms?
That's
so
a
like did her speech get better?
very important question. How the patient is evolving, and that may actually help you to determine what is the etiology of this particular pathology that this patient has. That's very good. Is the patient getting worse? So she's only now found her. We don't know over the 36 hours, her course. Was she getting worse or was she actually improving? That's a very important question. So we can only talk about when the daughter has seen her and is taking her to hospital. Is she getting any worse? Is she improving? So basically, there was no change that she really noticed with her. But that's an excellent question. When we come to talking about the etiology of this problem, you will see how that question is important, Omar. It's a very good question. So basically, she's just been the same since she picked her up, since she saw her. Okay.
Doc?
Yes.
I was thinking that maybe it would be hard to elicit this from a confused patient, but maybe we could ask her if she had any headache before.
Exactly. And you know what? Even if the patient is confused, you run all the questions that you normally would run anyway, right? But you're interpreting them in the context of acute confusion, and depending a lot on a witness, on another patient, another person who's taking the patient. But definitely, you still want to do due diligence all the time for every case. Headache is very important. Did the patient have any headache? Patient did not have a headache. She didn't report a headache. Does she have headaches in the past? And let me even go further. Does the patient have a history of headaches? So there are patients with migraine who can present like this. Migraine is a very interesting neurological disease. Patients can present with focal deficits on the background of migraine. So headache is always very important. We admitted a patient on the ward. This is a patient with no risk factors for cardiovascular disease. She was in her early 30s and she presented with a hemiparesis, which improved significantly. She presented with a 36-hour history, about a 3-day history, and her CT brain was normal. Everything was normal. In terms of imaging, lipid profile, everything. And when I met this patient, she was admitted on the weekend. When I met this patient, I elicited a history of migraine from this patient. So patients with migraine can present with the phenomenon hemiplegic migraine. So headache is important. It may indicate that the patient has had a vascular event with a hemorrhage or ischemia. It can indicate that the patient has another manifestation, intracranial manifestation, which can present with neurological deficit like a tumor. So you want to know the duration of the headache, the character of the headache, or it could be a headache disorder, primary headache disorder like migraine. Headache in anyone presenting with a neurological deficit is very important. And don't forget migraine. Very good. Anything else you want to get from this history?
I'm sorry, Doc. This has nothing to do with the history, but Chantal sent a message saying she's trying to re-enter the session. Right, I'm so sorry.
That's okay. No problem with the people dropping out. Okay.
Doc?
Right.
Oh,
Yes, Amelia. Go ahead, Amelia. Yeah. What else in the history?
so sorry. I was going to ask if she was able to get out any good words, but I realized that there was slurred speech. I was going to ask.
So she had slurred speech. She did respond to some of the questions that I said. She would say yes or no. And she, but she had slurred speech. And we'll talk a little bit more about speech. Okay, so anything else? So the history presenting complaint, you guys have gone through the most important points. And then as you go through the rest of the history, the principle in history taking of bringing up to the history presenting complaint anything that's pertinent from the rest of the history. So family history. So the rest of the history for me. Family history. Anything you want in the family history? Her family history. I haven't heard from Chantal. Any history? Family history, Chantal. Anika. Yes, I heard from Anika. Family history. All right, guys. In the interest of time, anybody jump in. Family history. What you want from the family history?
So I would want to know if the family has any history of.
Okay, you're very low. Low.
Can you hear me now?
Yes, no, I'm hearing you. Yeah.
Yes. So I want to know if the family has any history of chronic medical illnesses like hypertension or diabetes, as well as any history of neurological events like stroke.
Right. So her mother had hypertension and diabetes and died of heart disease. Not sure what kind of heart disease. Yes. So any cardiovascular complications, if patients have a history of myocardial infarction, In the family, you want to know the age, the gender, and the age. All right, the gender and the age, which will tell you about the risk. So you should have those cutoffs in your head as to in terms of myocardial infarction for men, for women. So we're trying to elicit any pertinent family history, which tells us about the patient's possible risk. All right, so family history, that was the only family history we got. And moving along down to social history that you will pull up and add to your history of presenting complaint. Omar you mentioned smoking. She's a lifelong non-smoker, or aka never smoker. She never smoked. She does not drink alcohol. You must ask about the use of illicit drugs from everybody, even though you may think nobody's doing these things. She has no history of illicit drug use. She lives on her own, and she's recently retired postmistress. So she worked at the post office. Right. Okay. So generally speaking, you get a complete history from all patients. You want to know about their living conditions, their lifestyle in terms of exercise, particular diet. You want to know about, for everybody, you should always elicit a history of age-appropriate screening, last pap smear, last mammogram, last colonoscopy, if ever done, according to the age of the patient, right? May not be pertinent to this history, but just cover history in general, okay? All right, so that's what we have so far. Now let's talk about the physical examination. What do you want in the physical examination? What's your approach to physical examination? You're going to examine everybody from head to toe, but there'll be certain things that you're going to hone in on physical examination. So let's start off with some. What do you want to start off with? Who is this? Hearing you. Somebody spoke?
So I'm not sure, do you want to start at the cardiovascular system and then work up, because we know there's a neurological problem, jump straight to a CNS?
Yeah, no problem. How about we start with the vitals? Let's start with the vitals for this patient. All right, so Omar, I'm going to give you the blood pressure. The blood pressure is 172 over 94 with a pulse of 72 regular. Yep, and the patient was afebrile, normal respiratory rate, normal oxygen saturation on room air. So those are the vitals. All right. Okay, any thoughts on the vitals?
I find the blood pressure is a little bit off, so I want to know when she took her medication when last, or if this is a sequelae of this event.
So we basically think she took her medication up until when she became ill. So yeah, so now off, it's elevated. So we're looking at a high blood pressure. You're going to flag that and come back to it. All right. General examination. This patient is so normal body habitus. So you want to look at the BMI. You want to assess the BMI, and you should do it properly. Do the height and weight, but you can assess a patient's BMI subjectively if you're not able to do that. But the nutritional status of the patient, the body mass index, right? Her general physical examination was unremarkable. There's no lymphadenopathy, no rashes, nothing else. Head and neck ENT exam, thyroid exam, normal. General exam was normal. Cardiovascular exam, Omar. In the cardiovascular exam, what in particular in the cardiovascular exam would you hone in on?
The component in the cardiovascular exam, I would say auscultation mainly.
Yeah, okay, auscultating for?
See if they have any murmurs. I know you said that, I don't know if the pulse rate was regular, but if it's not regular, suggesting atrial fibrillation, we could think that could be one of the reasons why.
Right, so that's very important. Right, what kind of stroke you get with atrial fibrillation?
Thromboembolic.
Yes, absolutely. So you get an embolic stroke. So the pulse, the rate, the rhythm. So her pulse was regular, but definitely if you have an irregular pulse, you're going to flag that. As you go through, you're going to elicit all these manifestations, these physical manifestations, but there are things you're going to flag because that's what's going to be, very pertinent to this patient. So the pulse, absolutely, because we know atrial fibrillation increases the risk of stroke by embolism, cardioembolic phenomenon, right? Okay, so regular pulse, normal, certainly like aortic stenosis increases the risk of, syncope, not so much stroke, but that would be a little less high yield. The apex beat is, markedly displaced. That tells you this patient has likely had hypertension and complications of hypertension, including hypertensive heart disease. Low yield in the current setting, but those are pertinent things in a patient presenting with a history of hypertension and any kind of acute problem. All right. Any features of failure? Any features of heart failure? Elevated JVP, etc. Any features of heart failure? Pedal edema? No, there are no features of heart failure. So her respiratory exam was also unremarkable. Her abdominal exam was normal. And so now we go to our high yield system, the nervous system examination. What do you want to elicit from the nervous system examination? And so here's where we're going to go into a little bit more detail, for our discussion. What do you want in nervous system examination?
Well, I would start off with the gait since, but if the patient can stand now.
Omar, I wouldn't start off with the gait because we would want to know her paw actively before we see anybody to walk, because yes, we have a history that she was, she could kind of walk, but she had difficulty walking, so you presume that she can do some kind of ambulation. But it's always wise to leave gait for last when you know the paw of the patient, which is why even in your nervous system examination of you're told examine patient's lower limbs. Your neurological examination, gait is last, because the patient, when you finish examining the patient, you realize that this patient is not likely to be able to ambulate. So I wouldn't start off there. I would start off with the mental status exam. You do it intuitively anyway. When you go to see the patient, you look at it, okay, this patient looks drowsy. All right, this patient is, super rose. The patient is comatose. So let's start off with the mental status exam, because it's what you do intuitively anyway. So we're going to do it objectively. Mental status exam. So I just mentioned the level of alertness. So is the patient alert? Is the patient drowsy? Is the patient stuporose? Is the patient comatose? So she was alert, right? So the level of arousal, right? Yep. And now you guys will finish up the rest of the mental status exam. I started it off for you. So the level of arousal, she was alert. What else do you want after that? So we're going through the mental status exam now, so you can check that off your to-do list.
Our attitude towards you.
That's very big, and the mental status exam is very objective. And if you think about it as being very objective, it's not like the mental status. There are elements of the mental status exam in psychiatry that are a little bit more esoteric like that. And Omar, that you would know about that, right? So,
To some extent.
yeah.
So assessing her cognition, so you want to know she's oriented to time, place, and
orientation. Good. Orientation in time, place, and the person. Day, month, year, place. Where are you? Corner Regional Hospital. Where? In the accident and emergency department. Okay. Person. There's a person. Do they know who they are? They can tell you who they are, but also are they oriented in person in that they are telling you that you are the medical doctor. You are not the police. You are not a soldier man. Oriented in time, place, person, orientation. Yes. What's next on the mental status exam?
Concentration. So
before we look at concentration, you're hitting all the right spots, but we don't want to leave out some things, because we will lump up high mental function, concentration, calculation, comprehension, judgment, insight, abstract thought all together for higher mental function, and you'll see why. So before we get there, let's talk about how you would. Sorry?
I was asking about level of consciousness with Glasgow, or we had that already?
Yeah, man. So she was alert. She was alert. So she's alert, oriented in time. So in her case, she was oriented in person, but she was not oriented in place or time. She was oriented in person only. She could tell us who she was, and she knew that we were doctors talking to her. So she was oriented in person only. You want to know about the speech. What about the speech? What about the speech, guys? What about the speech? So, level of arousal, orientation, the speech. What about the speech?
If it's clear and coherent.
All right, so we want to be very objective on internal medicine with the mental status exam because you're going to see why we need to be. You're going to see, you will see. Is it fluent? We want to know, is it fluent? What is fluency? Fluency is the ability to put 5 or more words together to convey a thought. So is it fluent? Fluency of speech. Okay, fluency. So the speech, is it fluent? You will pick up, of course, if it's slurred, but that's not really going to help you per se. You can talk about the nature of the speech, but for the purposes which you will see when we talk about resolution, is it fluent? All right. And then what is this, guys? What is this in my hand? What is this? Yeah, so what is that? You will say to her, Miss So-and-so, what is this? She says it's a pen. What is that?
Memory.
Naming. All right? Naming. Okay, can you say after me? No ifs, ands, or buts. What is that?
Repetition.
Okay, all right. So she was alert. She was oriented when in person. Her speech was fluent. Inconsistently though, she had normal naming, normal repetition. Okay, all right. Let's go into the higher mental function now. So I'm going to tell you 3 things: ball, cat, and table. Can you say them after me, please? Ball, cat, table. What are we about to elicit?
Short-term memory.
Short-term memory. We're going to reassess if she can recall how many objects at 1 minute, how many objects at 3 minutes, and you should. It's okay to stop at 3 minutes. All right. So short-term memory. Long-term memory. You will ask the patient something widely known by the public, or you can ask her personally if information which district she grew up in, for instance, if you can verify it from the relative. So ask about common knowledge. Yes. So long-term memory, right? So what else in the higher mental function? Higher mental function.
I know we give them that test where they have to redraw the shapes, but I'm not sure how.
They have to do what, Omar?
Redraw the shapes, like you ask them to copy the shapes.
Okay, right. So that's in the mini mental status exam, which is a very specific exam, which there are components of this in the mini mental status exam. You can do that. It is not standard part of the mental status, the general mental status exam that we do in medicine, but it's a part of the mini mental status exam. I'm going to give you some instructions, okay? Take your right hand, touch your left forehead, and take up this paper, fold it into, give it back to me. What are we assessing?
Comprehension,
the ability to follow more than 3 steps, more than a 3-step command. Comprehension. And you can use comprehension to give you other information. For instance, I ask the patient to cross the midline. Take your right hand and touch the left side of your body. You will find that patients who have a particular neurological event going on won't be necessarily able to do that. So not only are you assessing the ability to execute multiple step commands, but you are also going to be eliciting something which we're going to discuss in the localization of the lesion. So yeah, comprehension. All right. I'm going to start from 100. I'm going to ask you to take away 7 each time and go as far as you can go. So let's start off with 100, and you're going to take away 7 each time. That's called serial 7s. What does serial 7s elicit?
Attention, concentration.
So concentration, yes, definitely. So serial 7s, okay, doc. Patients tell me all the time, I'm not good with numbers, So what alternative can you use in these patients?
Spell word backwards.
Yes, spell the word world backwards. All right. So we have concentration, we have comprehension, calculation. Pretty much calculation will come out if they can do serial 7s. You can assess it by itself. So you go to the market, right? The patient says yes. All right. So if you go to the market with $120 and you buy something for $22, how much change should you come back with? Something like that. So calculation. All right. So then where else are we going to go? calculation. All right, so the more esoteric things, judgment, abstract thought, insights. All right, you can tell if a patient's insight is off, they're in the hospital and they're trying to leave the hospital bed. Insight is cleared off. You don't have to do any objective assessment to know that insight is off. Judgment, there are things that Omar, you know from psychiatry. You find a baby in a dumpster, what would you do? Don't ask patients things that have to do with morality. For instance, if you're walking down a dark road and you find $1 million in the bush, what would you do with that? Don't answer. You don't have to answer that question. But that's not a question of judgment in many cases. Insight. So yeah, judgment, abstract thought. Abstract thought has to be culturally oriented. So, many times we get tourists off the ship. I'm not going to ask the tourist from UK, one cocoa basket unless she's a returning resident, she's a Jamaican of some sort. It has to be culturally related. People live in glass houses shouldn't throw stones. All right, so we have a mental status exam. We're going to see why. So basically, all of her higher mental function, calculation, concentration, judgment, abstract thought, it was impaired. Her short-term memory, she recalled 1 out of 3 at 1 minute. Long-term memory was normal. Her long-term memory was normal. So that's a mental status exam. So I'm going to ask you to tell me what's cranial nerve. You're going to do your cranial nerves, right? Pick one cranial nerve for me out of all the cranial nerves and tell me which high-yield cranial nerve finding do you want to know. And I want you to write these findings down as we come because you're going to tell me where the lesion is. And you're going to tell me what the lesion is too. Okay, so which cranial nerve would you want to know what's happening with the cranial nerve? Pick one. Facial nerve, somebody? Which cranial nerve do you want to elicit? Hello?
Cranial nerve 2.
Why 2?
To see if, is it just any cranial nerve or any?
Give me one cranial nerve. Give me your highest yield cranial nerve. Give me your highest.
Okay.
What's
facial nerve then, probably.
Facial nerve, excellent. So this patient had flattening of the right nasolabial fold with sparing of the frontalis. All right. Cranial nerve 7 was abnormal. She had flattening of the right nasolabial fold with sparing of the frontalis, indicating an upper motor neuron facial nerve palsy, which we will go through. All right. Cranial nerve, all the other cranial nerves were essentially intact, except one aspect of her cranial nerve examination was abnormal. Not cranial nerve examination, but one examination. There was one abnormality that you picked up when you were doing her cranial nerve examination. Actually, you noticed it from you when you speak to her in the first place. It's not a cranial nerve deficit. But when you were examining the cranial nerves, you have to examine the eyes and check for extraocular movements, you picked up for sure that this patient had this abnormality. I'm going to tell you what it is. So it's not a cranial nerve problem, but when you were examining the cranial nerves, you picked this up. Or you may have picked it up from you got to the bedside in the first place. Okay. And that patient had a left gaze preference. She had a left gaze preference. It's not a gaze palsy, which is a cranial nerve problem, LR6SO4. She had a gaze preference. She was looking consistently to the left. Sometimes the eyes would deviate when you try to get her to look at you with primary gaze, but I would consistently deviate to the left. So she had a left gaze preference. All right. So let's go now to the power exam, motor exam, and you specifically want to know if the patient has any lateralizing, any focal deficit, right? So you want to know where the hemiparesis is. This patient had a right hemiparesis with grade 3 power. Grade 3 power, upper extremity, lower extremity. All right. Okay. No, so write those down, and I'm going to just go back to the mental status exam because I only told you about her. Let me give you the details about her mental status exam. So write this down for me, please. Actually, everything except comprehension was normal. Comprehension was normal. She actually followed multi-step commands. So comprehension was normal. Comprehension was normal. Repetition was impaired. Naming was impaired. And right, so this is her actual findings, guys. Let me tell you this. So whatever you had written down before, comprehension was normal, repetition was impaired, naming was impaired, and actually she was non-fluent. So fluency was decreased. Fluency was decreased. All right, so just rework that for the mental status exam. You have enough information to tell me where the lesion is and what the lesion is. All right, so write down all of the things. Think about it. Where is the lesion? What is the lesion in this patient? You would agree that this patient, your top differential would be top differential. Guys, what's your top differential here?
Ischemic stroke.
Yeah, a stroke. All right, I'm not sure why you said ischemic. Why did you say ischemic?
I perhaps should have, because of her underlying high cholesterol and hypertension.
Yeah, so you're really probably thinking ischemic stroke, right? But for now, I would just say stroke because it could be hemorrhagic. Hypertension, you can have a hypertensive bleed. So it could actually be hemorrhagic. So I would definitely, I'm with you all the way with a stroke. Because the reason you gave for why you said ischemic isn't the reason why it could be ischemic. You're using, the risk factors. So I want to just go back to the physical examination to make a point. You have all these physical examination findings. Is there something that you need to know about all patients who come with focal deficits? No, you have all these findings. So if you forgot to do it, like you guys forgot to do it before, you definitely want to do it now. What information do you want to know about the patient's background? Their background. Anybody presenting with a neurological deficit, what information you want to know about them specifically, each patient?
Their support system?
No. Something related to a deficit. So here we have a patient with hemiparesis, right? She also has some other findings. Handedness. You always want to determine from a patient their handedness. And I was hoping somebody would ask me, is left-handed or right-handed when I gave you all these physical findings. So she's actually right-handed, which means her dominant hemisphere is the left hemisphere, right? So she's right-handed. All patients who come with any focal neurological deficit, you want to determine their handedness. Is a patient right-handed, left-handed? All right, very important. You're going to see how and why. So you're thinking it's probably going to be a stroke, right? And there are various ways in which we classify stroke, but the standard is ischemic and hemorrhagic. And ischemic, it can be thrombotic or embolic. And when we go through, we talk about stroke a little bit more, we'll see what the differences are. Okay, so stick a pin on this patient. If you haven't been able to localize the lesion, we're going to start off now with where is the lesion, localization in the nervous system, and then you're going to tell me where the lesion is in this patient based on all the information that you've gathered from history and physical examination, right? So this is where we're going to go into where is the lesion, because this is what you're going to apply. It's this knowledge that you're going to apply to say what's happening with this patient. Sure, you're going to do the CT, but you may not get the CT today, which shouldn't happen, but it happens, right? So in the meantime, you're going to use your knowledge to determine what this patient's likely problem is. So when we talk about where's the lesion, there are many concepts, and what we're going to start off with in this section, we're going to be talking about the brain, right? Brain. So we have this central nervous system, and we have the peripheral nervous system. And we'll be talking about the central nervous system in this session, and specifically brain. So central nervous system is divided into brain and spinal cord. And you see this flow chart here looks quite complicated. We're going to break this down into its simplest terms to show you that localizing is very simple. And if you just kind of leave out all the noise, extra information that you don't need, you're going to see how just from your usual physical examination, you'll know how to localize the lesion. So first concept, central nervous system, brain, and spinal cord. All right, and then we're going to break down brain. We're going to look at the cerebral cortex and subcortex on this complicated diagram. These are the only areas that you're going to need to know. Now, when we talk about brain, you often think about the brain in lobes. But thinking about the brain in lobes, strictly speaking, is not going to help you precisely localize a lesion by itself, just a concept lobes and the functions of different lobes, right? But it does help. It does help to know that the temporal lobe, the processing of language is involved, at the temporal lobe. It's important to know that in the parietal lobe, there is processing of sensory information, for instance. You know that the brainstem has certain functions, you know what the structures are in the brainstem. You know, occipital lobe, you're going to be looking at processing of sight, right? We know cerebellum, balance, coordination, etc. But strictly speaking, the lobes of the brain, just only knowing the lobes of the brain and what they do does not help you to localize it. It provides information that will help you to localize it, but by itself does not. All right, and so these are just to highlight some of the key areas in the different sections of the brain and their functions. This is where the different lobes of the brain, in terms of key areas like the motor area, the sensory area, the language area, the vision area. This is how these lobes will help you. They provide information to help you, but by themselves cannot help you. But you still need to know various brain functional areas. Okay? So let's start off with brain. Right? So we say central nervous system. We divide into brain. We divide into spinal cord. So today we're going to look at brain. How do you now subdivide brain? How do you subdivide brain? How do you break down brain?
Cortex versus subcortex.
Cortex versus subcortex. You're gone a little ahead. Go back up a bit. Go back up a bit.
Supratentorial versus infratentorial.
Yep, supratentorial versus infratentorial brain. So concept number 2, we divide brain into supratentorial versus infratentorial. This is supratentorial below. So in the infratentorial, this is why we don't include the subtentorial. We're talking about we're not talking about cerebellum today. We're not talking about heart. We're not talking about brain stem. So this is infratentorial brain, right? So brain, so central nervous system, brain, spinal cord. Brain, supratentorial versus infratentorial. All right. So supratentorial brain. This is what we're going to be focusing on in the first part. Supratentorial brain. Now, how do you know if something is in the supratentorial versus the infratentorial brain? That's the first division, and this is going to be very, very helpful. Because immediately you will know, all right, is it this, or is it a cerebellum lesion, or is it a brainstem lesion? How do you know? Look at your patient. She has a right hemiparesis. She has a right oculomotor neuron facial palsy. Is her problem in the supratentorial brain or the infratentorial brain?
Infra.
Why you say infra?
Because the seventh cranial nerve is affected and it's in the pons.
Okay, but remember, even though the cranial nerve nuclei are there, remember we're dealing with tracts. Good. So nice segue. Remember tracts. So this is your first tract you will need to know for localizing the lesion. And I guarantee you that at the end of at the end of the 3 weeks, you'll realize that you only will need to know 4 tracts in detail. And when I say detail, you just need to know where it starts, where it crosses, and where it ends. So this is your introduction to the first tract, which is your corticospinal tract, right? Lateral corticospinal tract. So even though the cranial nerve 7 is affected, remember it's affected because of the tracts. So the root of the tracts, not necessarily the nucleus itself, right? So corticospinal tract. Anybody knows where the corticospinal tract comes from? Cortico and spinal. So cortex, motor cortex. You're moving from the cortex, and we don't need to know it goes around the corner, around bends, takes a bend, turns right under this and under that. You only need to know that it descends and it decussates at the distal medulla, and then synapses in the spinal cord. This is the lateral corticospinal tract, so it crosses at the distal medulla, right? The corticospinal tract. Corticospinal tract, remember the homunculus, carrying information from various parts of the body, oculomotor neurons descending and decussating at the distal medulla, right? And then your lateral corticospinal tract will go to the spinal cord, corticospinal. From there, messages are sent to your muscles. Very simple. Corticospinal tract. Running along with the corticospinal tract is the corticobulbar tract, cortex to the bulbs. These go to the cranial nerves, right? Corticobulbar tract. Motor nuclei of the cranial nerves. Corticobulbar stops at the bulbs, the cranial nerves, cranial nuclei in the brainstem, right? And they send information to the relevant skeletal muscles, right? Okay, so corticospinal tract, corticobulbar tract, same thing here. But just to make this point that when you have the corticospinal tract going to the spine, when it's going through the brainstem, you're going to find that it is going to provide information to the cranial nuclei. The information is usually both ipsilateral and contralateral, except for cranial nerve 7. That's why cranial nerve 7 is a high yield cranial nerve. You're a busy doctor in the emergency room. You have a patient with neurological deficit. Need to localize this lesion right away. Don't spend time examining this. Examine cranial nerve 7 first. High yield. If you have a question about it, for instance, you find out it's a lower motor neuron 7, then you go through all the others. But if you were to pick a high yield one, that's why we chose cranial nerve 7. All of the cranial nerves receive ipsilateral and contralateral supply information from the cortex. Cranial nerve 7, the information goes to the lower face contralaterally. All right. So based on the information I have told you, and this is cranial nerve 7, right? The difference between an upper and a lower motor neuron, which we won't go through in this class. I'll go through with you when we do cranial nerves in the brainstem. So based on this information, going back to your corticospinal tract, lesions in the supratentorial brain are going to produce neurological deficits where the cranial nerve findings are on the same side as the hemiparesis, versus infratentorial, the cranial nerve findings are going to be on the opposite side of the hemiparesis. That's how you're going to know if it's tentorial versus infratentorial. Infratentorial is what we so-called call crossed signs. So supratentorial, the cranial nerve problem, and the hemiparesis is on the same side because of how this tract decussates. In the infratentorial region, the cranial nerve findings will be on the opposite side of the hemiparesis. And now you're understanding the basis of this because you understand these tracks. You're going to just go home and just review this, right, to solidify it. You understand it because you understand the tracks. But in medicine, you have to find ways of remembering things quickly to do, MCQ questions or to quickly answer questions on rounds or in your exams. So quick way to remember is S. Supratentorial, same. The cranial nerve findings are on the same side as the hemiparesis, right? Infratentorial, different. So you ask yourself, because corticospinal tract crosses, therefore, if a patient has a right hemiparesis, what side of the brain is the lesion?
On the right side.
Huh? It's the
Right side.
Omar, go again.
No, I said the right side.
No, it crosses, Omar.
Oh, so on the left side.
Yes, the left, right? The left. So this is easy to remember. Wherever the hemiparesis is, because of the pathway of the corticospinal tract, the lesion is in the opposite side of the brain. So if you have a right hemiparesis, the lesion must be in the left side of the brain. Got it? You see, it crosses, right? Okay. So we know this patient has a right hemiparesis because of the course of the corticospinal tract. We know that the lesion is in the left side of the brain. All right, the left side of the brain. We know it's supratentorial. She also has a right upper motor neuron facial. All right, this does not. So it goes to the cranial nerve nuclei, yes, but it only feeds contralaterally, but it hasn't crossed. This hasn't crossed yet. There's no crossing here, so it's on the same side. Cranial nerve finding on the same side as the hemiparesis, so you know this patient has a supratentorial lesion in the brain. So supratentorial, the hemiparesis is on the same side as cranial nerve findings because of the corticospinal corticobulbar tract. Infratentorial, you're going to find that the cranial nerve findings are on the opposite side from the hemiparesis. So let me ask you, let's say this patient, Omar, let me solidify this point. Let's say this patient had cross signs. So she has a right hemiparesis, but she has a left upper motor neuron facial. What side of the brain is the lesion? It has to be the left side. Yes, it's opposite, always opposite to hemiparesis, because the corticospinal tract decussate at the distal medulla. You're going to be sending information to the opposite side of the body. Opposite side of the body, cortical to spinal, to tell those muscles to move, right? Opposite side. All right. So if you pick up the hemiparesis, that tells you where in the brain it is in terms of left or right, and that's important. Already, a lot of information. So we know this patient has a lesion on the left side, and it is a supratentorial lesion. Our findings are on the same side as the hemiparesis. So now, how do we divide supratentorial? So we're not going to go into infratentorial right now, because this is not what we're doing now. Supratentorial, how do you now subdivide supratentorial brain? How do you subdivide supratentorial brain now? Any ideas, guys? Somebody have ahead?
Subcortex versus cortex?
Cortical versus subcortical. Absolutely. So how do you know if it's cortical versus subcortical? So let's recap while you're thinking about how you're going to answer that question. So brain divided into supratentorial versus infratentorial. Supratentorial brain, same, the lesions are on the same side, the deficits are on the same side, cranial nerve and the long tract findings. That's going to be the opposite side of the brain, opposite to the hemiparesis. We divide supratentorial further down into cortical versus subcortical. How do we know it's cortical? If the patient has any cortical clues. So somebody says seizures. Any patient comes with a hemiparesis who has seizures, this is a cortical lesion. This is a cortical lesion because the pathophysiology of seizures is that it is spreading depolarization, right? Cortical, so it's cortical spreading depolarization. Just a quick summary. That's what seizures are. So if you have a patient who comes in with a focal deficit and they had seizures, whatever it is has affected the cortex. Seizures are a cortical phenomenon. So seizures. In the mental status examination, you will pick up that the patient has problems with executive function, so-called higher mental function, right? So she has a problem with her memory. She had a problem with calculation. She had a problem with judgment, abstract thought, insight. So those are some of the executive functions. So anybody who has any problems with it's called executive function, higher mental function, right? Cognitive function, those words are used interchangeably. So executive function or higher mental function, any impairment of that, and you'll get that from the history in the mental status exam. So those top two are the first two cortical clues I just went through. Now, aphasia. Did your patient have an aphasia, guys? Now, what's an aphasia? An aphasia is not to become confused with a dysarthria. A dysarthria is where there's a problem with the mechanics of speech. So this is where you had slurred speech. It's the mechanics of speech. It can be either buccal, lingual, or palatal. So they can ba 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 ba, la 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 la, or ga 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 ga. That's a problem that's in the brainstem. So it's not dysarthria. This is aphasia, and it's not dysphagia. Aphasia, whereby it's a problem with the processing of speech, the processing of language, and that will manifest in the patient's in the mental status exam, right? So it is not the mechanics of speech; it is the processing of language. So does this patient have an aphasia? Look back at your mental status exam. That's your mental status exam. Your mental status exam is going to tell you this patient has an aphasia. Does this patient have an aphasia? We said comprehension was normal, repetition was impaired, naming was impaired, fluency was decreased. So we would have started with fluency. We picked up fluency from before. Right, so that's the abnormality there. That's why you do the mental status exam, to help to localize the lesion in the nervous system. Does the patient have an aphasia? What are you using to help you with that? We need to know. Yes, what kind of aphasia? Go right ahead. What kind of aphasia does this patient have? Ah, awesome. Okay. Give me another word for expressive aphasia, please. Let me just make sure.
Is it Wernicke or it is Broca or Wernicke?
You know why I want you to say either Broca's or Wernicke is because that's going to tell you, that's going to help you to localize.
I think it's Wernicke.
You sure?
I'm not sure, honestly.
No, so why you said expressive aphasia?
Because the person she couldn't repeat and she couldn't name, so expressive. She couldn't but she had comprehension.
Okay, all right. So you are correct, but you see why you need to use Broca's, because Broca's is going to tell you where in the brain it is. So the patient has a Broca's aphasia. So this is why we do the mental status exam. One of the reasons we look at comprehension, we look at repetition, we look at naming, right? And we look at fluency. And if these are impaired in these particular patterns, they will tell you whether it is an expressive aphasia. Why I want you to use Broca's is you're going to see in the next slide versus a Wernicke's aphasia. Now, at your level, guys, you need to know the difference between Broca's and Wernicke's. All right, you have to know that. But there are several other aphasias which are kind of difficult to isolate. But if we, can use the same principle, what's the comprehension, what's the repetition, what's the naming, what's the fluency, you can actually localize, a lesion and define the actual aphasia. But you guys need to know Broca's versus Wernicke's, and you're absolutely correct. She had a Broca's aphasia. Comprehension was preserved, and everything else was impaired. All right, Broca's or expressive aphasia, but use Broca's so that you can localize the lesion, because Broca's area is in the left frontal lobe, the posterior aspect of the left frontal lobe. So what did we say again? She had a right hemiparesis, she had a right facial nerve, upper motor neuron type clearly, and so we know it's supratentorial. Now, because the hemiparesis is on the right, and you know the corticospinal tract, they can say it's at the middle, so cortex to the spine. So we know that that tract is going to be telling us about something that's coming from the opposite side of the brain. So I know it's the left side, and then she has a Broca's aphasia. Where's Broca's area? It is the left frontal lobe. So this is where the patient's lesion is. You have not ordered a CT, you have not ordered an MRI, and you know that the patient has a lesion in the left frontal lobe. Not only do you know it's left, it's supratentorial, but you know it's frontal. And so Wernicke's is all one you need to know, because there's a Wernicke's area. It's a left temporal lobe in the superior temporal gyrus, to be more specific. But you will know it's a temporal lobe lesion if the patient has a Wernicke's aphasia. So you see how the mental status exam helps you to determine if the patient has an aphasia, right? We know it's a cortex, the patient has an aphasia, right? Her executive function is off. Language is a cortical phenomenon. Now, let me make this point that was made just before. The dominant hemisphere is where the language center is. Oh, she's right-handed. Therefore, her dominant hemisphere is the left. So for real, she really does have a Broca's area. She does actually have a Broca's area lesion, right? Because her dominant hemisphere, which processes speech, it would be the left, because she's right-handed. You have isolated the lesion in just a few steps, all right? So that's aphasia. The next thing on our list is gauge preference.
McGhie?
Yes.
I have a question and a comment. Amelia says she got kicked out of the left back in the room. But with respect to handedness, if the patient is left-handed, that would mean the Broca's appearance on the right side, or would it still be on the left side of the brain?
So typically it would be on the other side, not the left side. So their dominant hemisphere would be the right hemisphere. Right, so that's where their language center would be. Right, so it would be the opposite. All right, so I missed all of that. Anyway, right, so once the patient has an aphasia, you can pick up where in the brain it is because of the different language centers in the dominant hemisphere. Now, we said this patient had a left gaze preference. So gaze preference is different from a gaze palsy. Gaze palsy is where the patient has a problem with their cranial nerves, LR6, SO4, right? You do your age to examine the vision, the range of motion of all the extraocular muscles. This is different. It's not a cranial nerve problem. The patient has a cortical problem. They are constantly looking to one side of one side. Both eyes are yoked, looking to one side all the time, right? You tell the patient, look straight ahead of you. They may temporarily look at you, but then they would deviate back to one side. And in this case, the patient had a left gaze preference. This gaze preference is going to tell you not only what the lesion is, not only where the lesion is, it's going to tell you what the lesion is. All right? In the brain, you have the frontal eye fields. Now, I'm going to break this down very simply for you. So you can just probably focus on me for a bit, my image. Now, in the frontal eye fields, you guys probably remember this from neuroanatomy, with the paramedian pontine reticular formation and medial longitudinal fasciculus, blah, 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 right? You remember that, the left medial longitudinal fasciculus, frontal eye fields. All I want you to remember is this. So the extraocular muscles are yoked. Left and right are yoked by their connection through all those connections, which you don't need to know at this level because we're not doing neuroanatomy. Now, the right, this is my right side, the right frontal eye field will cause the activation of the extraocular muscles, which will direct the eyes to the left, right? Direct the eyes to the left. The left frontal eye fields will activate the extraocular muscles, as you see in that diagram, which will direct the eyes to the right. Now, because both frontal eye fields exert equal force, equal stimulation of the extraocular muscles, the eyes are yoked. The eyes are yoked. So the patient they will be looking in the same direction. If I want to look left, if I want to look right, both eyes are going in the same direction, right? To ensure that I'm not having diplopia, etc. My vision is clear. Right? That's the normal function of the frontal eye fields, right? Now, this is a cortical process as well. Now, if I were to extinguish the right frontal eye field by a stroke, an infarct, right? The patient has an infarct of the right frontal eye field. What happens? This is no longer working. What happens?
You can't see well on the left side?
No, come tell me what happens with the eyes. We're talking about how the eyes would move. I remove the right. Right causes the eyes to deviate to the left. Left causes the eyes to deviate to the right. But because the pressure is the force that the innervation of the extraocular muscles with equal force. Let's just use that arbitrary word. The eyes are yoked. We look in the same direction, left, right, right? If I remove the effect of the right frontal eye field and I only have the left going on, what happens to the eyes?
They move towards the right.
Left gaze?
Yes, so they will deviate to the left. When you say unopposed left gaze, where will they deviate to? It's unopposed, yeah. So this frontal eye field is now unopposed. So where will the eyes deviate to? To the right.
Right.
Yes, remember, left, so right frontal eye field, eyes deviate to the left. Left frontal eye field, eyes deviate to the right. Equal force keeps them yoked. Take this one away, this one will do what it always does anyway, deviate the eyes to the right. Got it? Unopposed action, so we deviate the eyes to the right. All right? So if you have an infarct in the right frontal eye field, the effect of the left frontal eye field is now unopposed. The eyes will deviate to the right. Similarly, they're equal. This is pushing that way. This is pushing that way. If you remove now the left frontal eye field effect, what happens to the eyes?
It deviates to the left.
Right, so they'll deviate to the left because those are the extraocular muscles that are innervate, right? See it in the diagram, the medialis and the lateral rectus to cause the eyes to move in the opposite direction. All right, so right front field, you guys are silent and need feedback so I can know if you understand because it's very simple. I'm breaking it down to its simplest form. So right frontal eye field, the eyes will deviate to the left because of the effect on those extraocular muscles you see in the diagram there on your screen. Left frontal eye field will deviate the eyes to the right. But because both of them are exerting equal force, all right, in terms of the innervation, is sending messages, equal signaling to these extraocular muscles, think of it as equal force, then the eyes are yoked, right? Yoked, that's why you look, your eyes are not going off the place, right? They're yoked. So you remove this, so this is unopposed, the eyes will deviate to the right. If you remove this one, this is unopposed, the eyes will deviate to the left. So each one deviates the eye in the opposite direction. So if you remove one, the eye will be on the other frontal eye will be on opposed, and the eyes will deviate away from right. It will deviate to the where it normally would cause the eyes to deviate to. So right cause the eyes to go deviate to the left, left cause the eyes to deviate to the right. When they're both equally innervating, then the eyes are yoked. If you remove one and the other one is unexposed, the eyes will deviate to what we so-called looking at the lesion. So the lesion is an infarct. I've taken away the effect of this frontal eye field by an infarct. The infarct has destroyed this frontal eye field. It's no longer working. It's no longer in because of this infarct. So it's not working. So the left frontal eye field is unopposed. The patient will have a right gaze preference. Right gaze preference. They're always looking to the right. No matter what, they're always looking to the right. Right? What this tells you is that the problem is in the right gaze, the right frontal eye field, and that it is an infarct. So not only do you know where the lesion is, you know what the lesion is. It's an infarct. All right, stick a pin. What if this lesion was not an infarct? Could the same patient present with a right gaze preference? Could this patient also present with right gaze preference? The answer is yes. If this lesion is hemorrhage, if there is hemorrhage, which is going to cause increased stimulation of these extraocular muscles, this is going to override the function of the other frontal eye field, and the eyes look away from the lesion. Infarct, they look to the lesion. Hemorrhage, they look away from the lesion because their innervation, right, activation of the extraocular muscles is increased by an irritative process such as hemorrhage. So in a hemorrhagic stroke, the eyes actually are deviated away from the lesion. In an infarct, they look to the lesion. That's a quick way of remembering it. Looking to the lesion, looking away from the lesion. How you know what the lesion is? Because you know that patient has a right hemiparesis, a right facial nerve palsy. So the lesion must be in the left, right? So if the lesion is in the left and you're looking at the lesion, that means that this eye is unopposed, this frontal eye field is unopposed, then that means that this eye field is not working. Yes, that confirms that the lesion is the left. The patient has a left gaze preference. If it's not working, it must be something that has destroyed it, so poor blood supply to it, and that is an infarct. So not only do you know that it is that it is an obliterated lesion like a stroke, but you also know that it is an infarct and not a hemorrhage. In a case of a hemorrhage, over stimulation of the extraocular muscles, they will be looking away from the lesion because you know that the lesion must be on the left. So if they have a right gaze preference, they're looking away from the lesion, then it must be something irritative like a hemorrhage. And another kind of irritating lesion, just FYI, is a seizure focus. So have you ever seen sometimes patients have seizures and their eyes, when they're in the middle of a generalized tonic-clonic seizure, their eyes are deviated to one particular side? If the seizure focus happens to be anywhere in or around the eye fields, the frontal eye fields, then they will have a gaze preference going on during the seizure, and they'll be looking away from the seizure focus, right? That's just FYI for more information. So not only does the gaze preference tell you where the lesion is, it tells you what the lesion is, because the frontal lobe in the premotor area, that you find your frontal it's where you find your frontal eye fields. It's where you find your frontal eye fields, all right? And that's in the same general area as Broca's area. So this patient has a large infarct that involved Broca's area and the frontal eye fields, and we know that those are cortical events, all right? So gaze preferences are very helpful in telling you where the lesion is and what the lesion is. So right now, we have totally diagnosed this patient as having supratentorial, so it's in the brain, it's supratentorial, the deficit's on the same side. We know it's cortical. She has multiple cortical abnormalities, cortical manifestations, including a Broca's aphasia. We know where Broca's area is, and she has a gaze preference. We know where the eye fields are. So we know that this patient has a left frontal lobe lesion. Now, because of how the gaze preference is, we know it's an infarct versus a hemorrhage, right? It's something obliterative. All right, so you haven't had a CT brain yet, and you've localized the lesion, and you'll just go over that to reinforce it. All right, so we're just going to go through all the other cortical manifestations. So this is
Dr. McGhie. One quick question. Can you repeat what you said about the seizure focus, please, like in terms of the gaze preference?
Okay, so a seizure focus is going to do the same effect as hemorrhage in terms of sending causing increased stimulation of the increased signaling along that pathway to the extraocular muscles, and will override the other frontal eye field, so the eyes will be deviated away from the lesion, where in this case, lesion is a seizure focus or a hemorrhage. Right? You're sending more signaling along that pathway, which overrides the left one, the opposite one. Follow?
Okay, makes sense.
Okay, no problem. So if you know the patient is right-handed, and so their dominant hemisphere is the left hemisphere, right? The non-dominant hemisphere is the right, and in the right hemisphere, you're going to end up with deficits like hemi-neglect. And so remember, I ask the patients to take their right hand and touch the left side of their body. Your left hand touch your right elbow. If the patient does not seem to recognize a half of their body, this is the phenomenon of hemi-neglect. Patients will actually shave half of their face, wash half of their face. If you give them things to copy, they'll copy half of a clock, half of a house, half of part of a plant. If you draw, they'll leave off parts of half of the face. This is their clock. Tell them to draw a clock. They will only half of their world does not exist. Half of their world does not exist. This is very, very, very sad manifestation. Thankfully, not that common because, it's not as common as the other deficits. So hemi-neglect, all right? Hemi-neglect, in hemi-neglect puts the lesion in the inferior parietal lobe, right at the junction of the temporal and parietal lobe, right? So it's a parietal lobe lesion, all right, in the non-dominant hemisphere. Now, visual fields, if the patient is only seeing half of their world, this is what they're perceiving. They're only seeing half of their world, right? So this is your typical homonymous hemianopia. Homonymous hemianopia. All right, this puts the lesion, it makes it cortical, and it puts it in the optic radiation of the occipital lobe. Okay, so when the patients are indicating any visual changes, so that's also a very important thing to ask in the history. If the patients have noticed any problem with their vision, not just double vision, any problems with their vision, let them describe what it is. So if you pick up a homonymous hemianopia by doing visual fields, then that puts it in the optic radiation of the occipital cortex. So there are your list of cortical clues. There are other cortical sensory manifestations like graphesthesia. If I write in my hand the letter 8, I should be able to tell you that this is the letter 8, the figure 8, the number 8. You can give a patient a coin and ask them to feel, what is this with their eyes closed, stereognosis, right? So those are also cortical sensory, tells you that there's cortical sensory loss. So you know that your sensory cortex is involved. But by itself, usually that would be happening in association with any one of those other cortical manifestations. But just to give you that idea of how that comes in, graphesthesia, stereognosis. All right, so guys, now we said brain, we know why, we supratentorial, we know why cortical, we know why the presence of cortical cues, cortical clues or cues. So now in the subcortex, what are we going to use? So far we've used our cranial nerve examination, examination of the eyes, used our mental status exam, and we've done the power exam, motor exam. What part of the nervous system? I notice we haven't really focused on sensory. To help, but sensory, you should do a sensory exam, but you've seen that you haven't really required it that much at this point. What in the motor exam is going to help you to now tell us if it's subcortical? Subcortical is divided into two. This is corona radiata and the internal capsule. Corona radiata and internal capsule. Corona radiata, internal capsule. Corona radiata, internal capsule. Internal capsule has a posterior and an anterior limb. All right, what will tell you that it is in the corona radiata? What will tell you it's in the corona radiata, guys? What aspect of... I'm going to attempt to do this once again. I always fail, but I'm going to try. Never give up. Okay. All right. All right. Okay, so this is a lesion. This is in the corona radiata. All right, see that lesion? Now, if we were to take the same lesion, right? I probably can't reproduce that. But if you were to take the same lesion, okay? And put it in the internal capsule, how do you think the patients will be different? Take the same size lesion and put in the internal capsule. This is a very rough sketch, but it is to make the point. How do you think the patient will be different? This is how you're going to know if it's a coronary radiata versus the internal capsule, yeah? Yeah, Amelia.
I read that symptoms in the internal capsule, because the fibers are so close together, it produces like very severe symptoms. Dense.
So be very precise at this
level. Are you hearing me?
Yes, I'm hearing you. At this level now, you have to be very precise. When you say severe symptoms,
hemiparesis.
When you say severe symptoms,
I said hemiparesis.
Right, yeah, man. We have to be talking hemiparesis, cranial nerve, so on, so on, so. It's very, very precise, very specific. So yes, so versus coronary radiata, what do you get in the coronary radiata?
Weakness.
Yes, but what kind of weakness?
Face and leg.
No, use the same principle you just told me. You get a dense hemiparesis. All right, take this blue lesion here that I just put on a diagram. This lesion is going to be sparing all these fibers, all of these fibers. But if you take the same size lesion and you put it in the internal capsule, what happens? As you said, you get a dense hemiparesis because you've knocked off all of these fibers. So lesions in the coronary, in the radiata, this is where the grade of power is. So you need to know how to grade power. You guys know how to grade power, right? The Maris scale, grade power. So 0 is
no power.
Yes, 1. So take it away. Go 1, 2, 3, 4, 5.
I think 1 fasciculation.
No, don't use that word. Fasciculation is a pathological abnormality, which is a hard sign for lower motor neuron disease. So don't say fasciculation, you mean a flicker of muscle movement. So you guys have to be careful about your terms, right? But now is the time to speak out so that you can get corrected. So yeah, so not physically, you're talking about a flicker of movement. So you see a flicker of movement, right? Grade 2, grade 3, grade 4, grade 5. You guys need to know how to grade weakness. I don't want to spend time on that, but put that on your to-read list. So when a patient has a lesion, but yes, being a flicker, when the patient has a lesion in the coronary radiata, the weakness is usually mild because all of these have spared, right? Because all the fibers come together to go into the internal capsule, then you're going to find that the lesion, the deficit, is going to be more pronounced. These are the patients who come with 0 or 1, just a flicker of movement. So if you have no cortical findings, so you say it's in the subcortex, and the patient only comes with a pronator drift. Sometimes, I'm going to tell you about pronator drift, right? Sometimes patients, you examine a patient and the patient seems to have normal power, right? A way of picking up easily if the patient has subtle weakness, mild weakness, is to do the pronator drift. Anybody knows the pronator drift? Pronator drift. So you ask the patient to extend their arms out, palms up, right? And close their eyes, and then you are going to just observe them for at least 10 seconds or so, and you'll find that they will prone and drift down. Sometimes they prone more than they drift, sometimes they drift more than they prone, but pronator drift will pick up subtle weakness. When you examine the power, it seems like it's grade 5, you can pick up subtle weakness. A lot of the patients who have just mild deficit, if you don't do pronator drift, you'll miss it. That's a lesion in coronary radiata. Mild deficits, we're talking about, 4 plus. So you can use pluses in the higher scales, right? So mild deficit versus intense hemiparesis, 0, no movement at all. Coronary radiata internal capsule, it would depend on the degree of the weakness when you do your motor exam. Now, you can further divide it into posterior and anterior limb, and the easiest thing to know is that in the posterior limb, you also have sensory findings, all right? Sensory findings. Now, the homunculus tells us that depending on where in the brain the lesion is, the patients may be weaker in their arms and their legs. They may not necessarily have a grade 3 power throughout, like our patient, right? So if the lesion is typically affecting more the upper extremities or something, so something more in the MCA territory, the arms will be weaker than the legs, right? Which is hanging in the intercerebral hemisphere. That's just to elaborate a little bit more about the homunculus. But that's not really going to help you to localize a lesion precisely like what we've just done. All right. So this is just a quick sort of recap. It's important to know if the patient is left-handed or right-handed. And so in the left hemisphere versus the right hemisphere, you're going to find that the biggest difference is whether there is a presence of an aphasia or not, because of the dominant hemisphere hemi-neglect. You're going to find in patients who have where the lesion is in the right side of the brain, in the right side of the brain where so the right parietal lobe. Hemi-neglect is going to be one of the things that will differentiate a lesion in these patients, right? Gaze preference, visual field, depending if the lesion is in the left, then all these things will be on the right. And where the eyes will deviate, it will depend on whether it's an infarct or a hemorrhage. Left hemisphere is where language is usually it's where your language center is. The patient will have an aphasia. Hemi-neglect, the patient's problem will usually tell you it's in the right hemisphere. So essentially, just summarize what our patient had as we go through how we divide the nervous system, right? Supratentorial, we know where the cranial nerve deficit is and where the long track findings are. On the same side, supratentorial brain, we divide into cortex versus subcortex. Absence of cortical clues makes it subcortex. Any of the cortical clues will clearly make it cortex, and then you can also pick up where in the brain, which lobes. So you can see you can't start off from lobes. You have to start off how we started off, right? And then in the subcortex, the strength, the grade of the deficit will tell you whether it's cortical, whether it's corona radiata or internal capsule. And the presence of any sensory findings will help you to distinguish whether it's a posterior limb or internal, or the anterior limb if you think it's an internal capsule lesion. And that is essentially where we are going to stop for today in terms of localizing the lesion. All right? Any questions? So where is our patient's lesion? Where is the patient's deficit? Where is the patient's deficit? What is the patient's deficit? Let's pick up for the management of this patient. What investigations do you want to do for this patient with stroke? What investigations do you want to do? Do you want to know if she has any investigations? She doesn't have a CT brain as yet. She's awaiting a CT brain. Her CBC UNE's liver function tests were normal. We don't have fasting lipids yet. What investigation you want on this patient right away? What investigations do you want? Guys, you know where the lesion is, but you are going to do investigations. What investigation do you want?
A CT scan?
A CT scan. All right. Do you think the CT scan is going to show anything?
Maybe.
I think it might. Not sure exactly, but the frontal cortex area might be hypodense.
Okay. All right. Omar, how long now has this patient had her deficit? We think she was last normal 6 hours ago. We're not sure, but yeah. All right. Let me put it to you. If her CT brain was normal, what would your thoughts be?
It means that she had it for a good while. It doesn't exclude that she had a stroke, but it just means that if she had it, then it probably resolves.
Okay, so actually what it is that in the first 24 hours after having an ischemic stroke, a CT brain might be normal. A CT brain might be normal in an ischemic stroke. If the event happened within the past 24 hours, right? So then, in her case, we would expect it to be abnormal if we presume that her deficit, that her problem is more than 24 hours. It could be less than 24 hours. So if you have a patient that you just went through the neurological exam using just only 2 tracks, right, and your knowledge about cortical versus subcortical, etc., we just went through, and you localize this, you say this lady has a left frontal lobe infarct. Why is my CT scan normal? It's because this perhaps happened in less than 24 hours, where you will not necessarily pick up an infarct on a CT. So why do a CT scan for then anyway? We do it to rule out hemorrhage, because the management of hemorrhage and infarction is different in terms of stroke management, acute stroke management, right? So the CT brain can be normal within 24 hours of a deficit, in which case an MRI will actually pick up the lesion. No, if it's a really massive territory and there's cerebral edema, sometimes you will pick it up under 24 hours on a CT. So we do the CT brain to rule out a hemorrhage definitely. In under 24 hours. Beyond 24 hours, we should be able to pick up a deficit, unless the deficit is in what part of the brain. The lesion is in what part of the brain. In what part of the brain, a CT scan is not the best imaging modality to pick up an infarct. Everybody knows there's just too much going on. Too bony structures in that part of the brain. So you do a CT scan and you might miss an infarct, which is why when you pick up a lesion, as you will all be able to do, and you pick up a lesion, you say, okay, this lesion is in the cerebellum. I'm not going to ask for a CT, or I will ask for a CT to rule out hemorrhage, but I know that what I really need is an MRI. It's because, so any lesion in the infratentorial brain, there are lots of bony windows, lots of bony shadowing, so infarcts can often be missed or not picked up well by a CT scan of the brain. So that's where an MRI would come in. MRI comes in for one, early identification of an infarct on the 24 hours, which because of resources, everything you do is resource driven. People don't have money to be spending on an MRI unnecessarily. If you clearly have picked up this lesion and this patient's history is on the 24 hours and the CT brain is normal, you don't necessarily have to send it to an MRI, because that's money it's not going to change what you're doing, because you're going to treat the patient like a stroke. So 1, on the 24 hours. 2, if you suspect that the lesion is in the posterior fossa, because of the bony shadowing, and MRI will pick up the lesion where a CT won't. You still do the CT though to address the ruling of hemorrhage. All right. So investigations, you guys, you want lids, you want her random blood glucose, or you may want to screen her. Anybody comes with any cardiovascular disease, you should screen them for diabetes. But those are definitely your top your top choices. What are we going to do about this patient? When you're assessing her cranials, you'll assess her gag. So her gag was intact, but in patients who have a decreased gag, or you try them with swallowing, they may need to have an NG tube for supportive care. So these are some of the things that you want to think about when you're seeing the patient. Now, this is leading me to the point about why do patients with stroke? All right, so I've done the CT, and the CT confirms a lesion that I would have picked up anyway, because I know how to localize a lesion in the nervous system. I'm speaking on your behalf. So you picked it up, you know it can stroke. Why do we admit patients? We admit patients in hospital and we keep them for roughly about 48 hours, because we want to make sure the patient doesn't develop any complications associated with stroke. Number 1, we want to make sure that we manage the patient's blood pressure appropriately. So I'm going to talk you through the key points, and then I'm just going to show you the guidelines that I'm referring to. But these are the key points. Now, Omar, you asked me for the blood pressure, and I told you it was 172 over, what did I tell you? 172 over 94. What you want to do with that blood pressure, Omar? Because the nurse is going to call you. Going to say, Dr. Omar, this patient's blood pressure is very high. You're the intern. Please come and give this patient something for their blood pressure. What do you do? Go or not go? I mean, you always have to go. But are you going to give them something, or are you going to leave them alone with their 174 over 92, Mr. Dr. Omar, to soon be the intern that the nurses will call about this blood pressure? What do you do?
I'll probably give them one antihypertensive.
Okay. You have just done the patient harm. No antihypertensives. All right. And listen, guys, when we're doing these sessions and you say something wrong and I say things like that, don't feel anyway. This is a learning. This is a learning process. And when you actually speak up, then you get to know what your deficit, where your knowledge deficit is, and I get to know so I can address it. So, like, don't worry about these things. Yeah, because that's actually the problem with blood pressure. Now, I want you to remember at this stage of the game, you need to have very scientific, you need to have the jargon when you for your discussion for your exam writing, for your OSCE discussion to the patient. You would use jargon. So remember the ischemic penumbra. The time it takes for you to explain blah 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 blah, you just say we do not lower the blood pressure unless it exceeds 220 over 120 in an attempt to preserve the ischemic penumbra, Omar. So 172.94, leave her alone. She's gonna be okay. Anything above 220, 120, we have to do something about it because we want to preserve the ischemic penumbra. So around every infarct is an area of very tenuous, very vulnerable blood supply. Then when you drop the cerebral perfusion pressure by lowering the blood pressure in the acute stroke phase, then you will cause the infarct to expand. The patient who came with a grade 3 power leaves with a grade 5 power in the name of getting a blood pressure down because of the compensatory pathophysiology. We call this permissive hypertension. You will say, nurse, we are going to permit that hypertension because we need to preserve the ischemic penumbra. But no, you will actually, she'll think you're being very verbose. You'll say, after a stroke, the patients need to maintain their blood supply to their brain to keep that area of infarct from expanding. So it's okay, nurse, 174, 172.94, it's okay, she's going to be all right. Call me back if it's greater than 220 over 120. And a good doctor will write that in the plan so the nurses will know that we are tolerating. So it's permissive hypertension. We are going to tolerate a blood pressure up to 220, 120. It sounds really scary, but that is like physiology and it's backed up by guidelines. So no, you won't lower the blood pressure, but I know you intended to do good by this patient. So remember the ischemic penumbra. All right, so that's the blood pressure management. Now, if the patient has hypercholesterolemia, which she has, you check the lipids. You may want to optimize and put her on high intensity statin. She's on 20 milligrams. That's a lower intensity atorvastatin. You're going to want to go to between 40 up to 80. Optimize the lipids, right? So blood pressure, lipids. You want to always start off before we go into that, guys. Don't take it for granted that you think about that airway, breathing, circulation. So that's the blood pressure. In terms of breathing, one of the reasons why we keep patients also in hospital is that patients can, if patient has a stroke that's affecting their respiratory area, the patient may need support. But other than that, patients can develop respiratory complications from stroke. They may aspirate. You can't control your airway. You aspirate. The patient now has an aspiration pneumonitis or an aspiration pneumonia and requires antibiotics because any infection on board, so anywhere, whenever patient has fever with any kind of intracranial events, especially infarcts, this can also lead to worsening in terms of the hemodynamics that fever carries with it. So patients can aspirate. You check for aspiration. Chest examination is normal. You treat for aspiration. If it is there, you're going to have to ensure that the patient has a nasogastric tube because they can't swallow. So you're going to always be at risk of aspiration. Nurse, head up in the bed in terms of feeding. You have to factor this in terms of the further management of the patient. This patient may need to go home with a nasogastric tube. So when we talk about discharge planning, that's something that you're going to make a mental note of, and you're going to deal with that when you're talking about discharge planning, right? Other reason why we keep patients in hospital is that we know that patients with cortical events can develop seizures, or even if the stroke is associated with significant cerebral edema, the patients can develop seizures. So seizures can complicate strokes, so we're monitoring for that as well. So those are the reasons why we keep patients in hospital. And if the patient has any associated comorbidity, which may be related to the stroke or not, take atrial fibrillation, we're going to have to make sure that atrial fibrillation, the ventricular response is appropriate, we're not having a rapid ventricular response that is uncontrolled. And you also need to start to think about discharge planning. Patients with atrial fibrillation will need to be on an anticoagulant to prevent future stroke, but you can't start the anticoagulant right now. You can start the antiplatelets, which I'm going to go into. So managing anything else that is wrong with the patient, comorbidities, diabetes, and so on. Now, Back to the whole issue about etiology. So there was a table I showed you about ischemic and ischemic thrombotic embolic. You spoke about the time course. A patient with an embolic stroke, right? Patient who has atrial fibrillation, they will give you a classic history of the deficit being worse at the onset. So the patient will note, or they relative that they couldn't move the left side at all. All of a sudden, they were talking face droop, hand locked. Patient, it has a dental paresis, grade 0 power. By the time they get to the hospital, they can move it a little bit, they're at grade 3. So the embolus goes boom, and it blocks up the vessel, and then their fibrinolytic system is activated, and your body starts to break down that clot, and then it gets smaller, and the deficit improves. That's a classic example of an embolic stroke. So just to mention that, I was really talking about dealing with atrial fibrillation if it's present. All right. Now, in terms of medications now, so we clearly did not prevent the stroke. So primary prevention is out of the window. So our family physician who is going, person interested in family medicine, Amelia, primary prevention is what we really depend on you for. But when we have a patient now who has a stroke, we have to focus on secondary prevention. This is where the pharmacological management will come in. So what medications are you going to put the patients on for secondary prevention? Think about it. Just give me 1 second. Morning. Yeah. Take her number. Let me call her back, please, operator. Can you take her number for me? Let me call her back. All right. Thank you. Yes, guys. What medications are you going to put the patient on?
So like aspirin, anticoagulants.
Yes, you're going to put the patient on aspirin. Did you say anticoagulants?
Or is it I can't remember. I know it's anticoagulant versus antifibrinolytic. So I was thinking of different therapies.
Versus. All right. So this is where in final year, precise and clear. So aspirin, clopidogrel, those are antiplatelets. Antiplatelets. So I know we use the term anticoagulant loosely, but those are actually antiplatelets because they don't affect the coagulation cascade. So the coagulation cascade, your intrinsic pathway, common pathway, on that, those things that affect the coagulation cascade are things like heparin, Coumadin, this is warfarin, the novel oral anticoagulants like their direct thrombin inhibitor, anti-activated factor 10 inhibitor, all those are anticoagulants. These are antiplatelets. All right, so you're going to put on an antiplatelet. I agree with you. Aspirin, definitely you're going to put this patient on aspirin if the patient doesn't have any contraindications. Are you going to put the patient on anything else along with aspirin? Anything else along with aspirin? So you can put the patient on clopidogrel, right? Clopidogrel. And for patients who present, so the current guidelines are that you're going to put the patient on aspirin. We put the patient on their varying doses. We use 81 milligrams of aspirin. And we're going to put the patient on clopidogrel, 75 milligrams. Each of these are once a day. Make sure there's no contraindication to being on any antiplatelets. And patient is going to stay on dual antiplatelet coverage. As long as she didn't have any cardiovascular event, she didn't have an MI, you can stop one of the antiplatelets after the guidelines say 21 days. Now, to avoid confusion, just tell the patients after 1 month, you stop one of the antiplatelets. Usually we stop clopidogrel and they stay on aspirin. All right, and they stay on aspirin indefinitely. This is secondary stroke prevention. Does it always prevent stroke? No. You have to modify all the other risk factors, and even so, there is still, highlight to you, it's a 2019 update of the 2018 guidelines for the early management of acute ischemic stroke, and I'll just drop it in the WhatsApp group for you to look through. Now, when you look at it, you're going to be like, seriously, am I supposed to read this whole long thing? Just focus on, I just screenshot these things just so you can just focus on the tables, right? We said airway breathing, ABC, don't give anybody oxygen just because oxygen is a drug. If the sats are less than 94, then you give oxygen. So I'm just showing you the tables, right? This is the blood pressure, right? This is the blood pressure that we're talking about. You will see this blood pressure here about 185, 110. This is if you're going to give the patient fibrinolytic therapy. So you mentioned fibrinolytic therapy. In stroke centers, we don't have any proper stroke center or stroke unit. Patients come in. The patient just was having dinner with their family and they noticed that they had a droop. They carry them into the hospital. These are the patients you want to, you want to have reperfusion therapy. It can be fibrinolytic or thrombectomy, right? So we haven't mentioned that. We don't practice it, but it's ideally the way to go. But it requires a proper stroke center where you can get a CT right away, not like when you can't find a portal. And you have to be able to manage these patients when you give them fibrinolytic therapy. So the blood pressure in this case you would have to lower to less than 185, 1. So this is just to mention that. And the drugs we use for fibrinolysis, IV alteplase can be used. All right, so fibrinolysis is something that you need to know about for acute reperfusion, acute management reperfusion. Is a patient we know when the deficit occurred, and there is a window within which, and I'm going to leave that for your homework. All right, guys. So right, but in terms of blood pressure, we said 220 over 120. Right, definitely can't give them thrombolysis, and these are the patients who you keep that way. When do you reinitiate or initiate blood pressure management, guys? After 48 to 72 hours, right? After 48 to 72 hours, not before. After 48 to 72 hours, make sure there's no hypoglycemia, which makes prognosis worse. Nothing causing fever. Hyperthermia makes the deficit worse. Hypothermia doesn't improve, contrary to what the thinking is. DVT prophylaxis. So you can give the patient sub-Q heparin, even, sometimes that's the other complication that can happen post-stroke. Hemorrhagic transformation. We didn't mention that. Hemorrhagic transformation of an infarct. So the patient comes in with an infarct and then they bleed into the infarct. That's if you see somebody's neurological status change, their GCS falls, their level of alertness, the deficit worsens, you have to rescan them. The infarct may have extended, or they can have hemorrhagic transformation of the infarct. Actually, you can actually use prophylactic subcutaneous heparin for DVT prophylaxis, right? We use on the ward heparin, 5,000 units sub-Q twice a day. Its benefits in terms of preventing DVT in the patients who are not able to ambulate actually outweighs the risk of having hemorrhagic transformation. But ideally, what the patient should have is pneumatic compression, intermittent pneumatic compression. So you see these devices that intermittently inflates and on the lower extremities, right? Nutrition. Make sure we feed the patients. If you have to give a nasogastric tube, we give a nasogastric tube. And we will teach the patient's relatives how to use a nasogastric tube. And when they go home, their ability to swallow, you can try them periodically with, at the right angle so that they don't aspirate. Requiring a nasogastric tube, then you want to consider giving them a gastrostomy, a PEG tube, which is better in terms of aesthetics and more comfortable for the patient. So those are things you want to discuss in discharge planning. So aspirin, yeah. So aspirin alone can be given, right? You can also give aspirin, and we didn't mention this, extended release dipyridamole. So this is aspirin and the extended release dipyridamole. And you see, this is our varying doses. We use 8 to 1 because that's what we have here. Extended aspirin is extended release dipyridamole can be given. Clopidogrel can be given. So you can give either of these, but the combination is actually what we practice. We give it for 21 days, as I said, just tell the patients 1 month. It definitely, in the cases of minor ischemic stroke, this is what we will do for this patient, and you stop the clopidogrel after 21 days. So these are your options for secondary stroke prevention. All right, we manage the cholesterol, lower the cholesterol. Want to get that LDL, that's the bad cholesterol, down based on the patient's risk for atherosclerotic cardiovascular disease. There are different scores that we can use to calculate their risk. All right, and so on. These are just how you just don't have to be the whole document. Just focus on these tables. Stroke rehab. We refer all our patients to the physiotherapist. We try to mobilize the patient, sit them out of bed. Try to get the patients to, for the patients who can actually ambulate, we encourage them to go to the bathroom with assistance. So try to ambulate the patient as early as possible. We're going to, for discharge plan, make the patient gets a referral to the physiotherapy department for ongoing limb physiotherapy. For the patients whose speech has been affected, you refer them for speech evaluation and speech therapy. Nutrition, we address with the NG tube, possibly nasogastric, possibly gastrostomy. And you teach your relatives about turning bed for the patients who become bed bound. You want to decrease the risk of developing ulcers. It should be turned every 2 hours. You know, you get a ripple mattress. It's the big mattress, that spongy foamy thing that looks like a large egg crate. And so these are all the things that you discuss in discharge planning. We want to give the patient an appointment within the next 2 weeks to come to see what the blood pressure is, because now we want to try to lower the blood pressure to its ideal target of less than 140/90, right? And so we will see the patient on the ward review and check how the patient is doing, all the issues that they were discharged with, and optimize their blood pressure control. So that's the management of acute ischemic stroke, guys. And having done our virtual rounds and our first session of where is the lesion, we've learned how to localize a lesion in the brain, specifically supratentorial brain. In so doing, we've covered the mental status exam. We reviewed 2 of the relevant tracks. We've spoken about other various aspects of the neurological examination, right? And we've covered ischemic stroke management, and I'm doing cases which are common. I always do this case with every student because this is what we admit every single day: stroke. And so you have to know how to manage this. And in covering these topics in our session today, we won't spend this much time again going forward. We've covered the approach to taking the history of a patient with a chronic disease, and some of the practicalities of doing so, including checking the medications and so on. We've spoken about how to tie in all the various historical points, and how to, we have to examine everything about the patient, how to hone in on the key systems, and then of course how to use evidence-based management to determine what tests you're going to do, right? And how you're going to manage your patient. So back in the day when I was training, 220/120 was just like, whoa, no. But studies show that outcomes are better when patients are allowed this permissive hypertension. So that is it for our first session on our first virtual rounds, and we've gone over time because of our glitch and our first session of localizing a lesion in the nervous system. Subsequent virtual rounds will not necessarily be connected, so we'll end up kind of doing 2 sessions. We'll do the case first, and then we'll pick up from localization of a lesion in the nervous system. So your assignment is that you're going to review infratentorial neurological deficits. What's the approach to infratentorial? So what's in the infratentorial region, guys? 2 divisions, 2 functional divisions, 2 structural divisions, right? In the infratentorial region. So we've simplified it. But remember, all these are interconnected. But for the purposes of localizing, we're talking about two functional areas. It would be the cerebellum and the brain stem. So let's review the cerebellar features, brain stem manifestations. So let me just help you with your homework. Now, when we're talking about brain stem, what part of the nervous system examination is going to be very important for localizing a lesion in the brain stem? We touched it today, but we're going to go into detail with it now. Which
cranial nerves?
Cranial nerves, absolutely. Give me a letter in the alphabet. First part of which, give me a letter in the alphabet, which is going to help you with your homework for the cranial nerves, for localizing a lesion in the brain stem.
D?
Yes, the D's of the brain stem, absolutely. So guys, going right to all the D's of the brain stem: diplopia, dysarthria, etc. All right? Get creative. So decreased sensation, etc. Right? Deafness. So the D's of the brain stem. So look at the structure of the brain stem, look at the cranial nerves and the functions that they subserve, and therefore these are the D's. You're going to pick up the D's from the history, and then pick up the D's from examination. So, and then cerebellar science. And as I just mentioned, just review the guidelines that I'm going to send you to consolidate what we learned today, and just also to just get a little bit more info on emergency reperfusion therapy, that is giving fibrinolytic therapy, alteplase versus mechanical thrombectomy. All you need to know is what drug is given, what time frame. So the patient can have a neurological deficit from 4 days ago, they would not qualify. So what is a cutoff time frame? Which is why you have to have a stroke unit. These people are actually sitting at the hospital, and you activate them and they get out, and it's door to needle time. When they get through the door of the hospital until when they get needle for fibrinolysis, it has to be a certain time. The deficit has to have been going on for a certain time. There's a different blood pressure target. So you can review this in like 15 minutes from the document and just report it back in like 2 minutes, all right, to complete that whole topic. All right, so that's your assignment for next session. So on Thursday, we'll do our first neurology session, which is we're going to do the hand examination and how the hand examination allows us to come up with differentials for rheumatic diseases, and this serves as your crash course introduction to rheumatology. Any questions on what we've done today? Any questions on what is to come?
Hi, Dr. McGhie. Yes, I have 2 questions.
Yes.
So my first question is the aspirin and the clopidogrel. What's the route? Is it oral?
Yes, so it's oral. All these are oral agents. You're going to go home with that on their prescription, right? So we send her home on aspirin 81 milligrams once a day, clopidogrel 75 milligrams once a day, and we gave her high intensity statin. She was actually her lipids were quite high, LDL was very high, so she was not, her atorvastatin dose was actually suboptimal. We sent her home on 80 milligrams of Lipitor, right? And yes, right. So all these are oral. So you only use parenteral for acute stroke, for acute reperfusion, IV alteplase, and another one. When you do your homework, you'll tell. Second, a comment?
Yes. So the second one was, you said within the first 48 hours. Were you referring to the hypertension?
Yes, the hypertension. So the guidelines say 48, 72 hours. We're not going to lower that blood pressure. Give me 1 second. Morning. Yes. Mm-hmm. Okay. No, you can just take my number from me, please, and I'll call her back. I'm actually teaching, which is why I can't take these calls because they're not really urgent. Just take the number from me. Oh, but nobody expected her to be here. She can't just pop up like that. Right. Does she have a clinic? Okay. All right. Tell her to stay there. I will send somebody to help her, but that's not really appropriate. All right. Okay. Okay. You had another question, Michelle?
No, that was it. It was just those 2.
Okay. Any questions from anyone else? Okay, everybody's good with this first session. Just review and comment any questions you have. When we resume the next session, I'll always start off with 2 cases, a case or 2 that will show you that you can actually do this. All right, you just need to, just review, comment with any questions you have, and then we'll practice the next session, the first 5 minutes of the next session next week of localizing. I'm going to give you 2 cases, and you'll see that you can actually localize the lesion using the principles we just went through. All right, then. That's it. Okay, everyone. Take care.
Thank you so much.
Thank you.
Thank you guys. Bye.
Thank
Take
you.
care.
Thank you.